the stage of a histological level where we can interpret the details of the retinal layers so closely. So looking at the interpretation, there are two major interfaces you need to identify: the vitreoretinal interface and at the level of the retinal pigment epithelium. So you have a high reflectivity here, you have high reflectivity there, and whatever there is in between, that you have to interpret. Now, the relative OCT signal reflectivity is based upon the character of the tissue which you get in the middle. So you get it on the vitreoretinal interfaces, which I just mentioned, then the nerve fiber layer, the retinal pigment epithelium, the scar tissue, the choroidal neuromuscular membrane, and blood. Then the moderate reflectivity is by retina, choroid, and vitreous bands, and you have low reflectivity, which is for vitreous debris, posterior hyaloid, outer retina, and noise, and I'll show you some of the pictures for this. And when you have minimal or absent reflectivity is by vitreous, aqueous, siliconoid, cyst, and the shadowing which occurs when blood is present, and the shadowing is actually minimal reflectivity. Now, how do you go about reading an OCT? You read an OCT just like an ultrasound. The superficial structures which are present in an ultrasound affect the underlying tissue. So you need to understand that, and you need to understand the reflectance pattern. You need to know which machine the OCT has been taken on, whether it's a time domain or SD-OCT, and then whether you have a line scan, whether it's a horizontal scan, vertical scan, or oblique scan, it's a raster scanning or volume scan. And then you also need to identify the artifacts and then go ahead and do the structural analysis. Now, when you present it with a scan like this, you have to say, is it a horizontal scan or a vertical scan? How do you go about identifying? Just look at the scan here, look at the structures on the ends of it, and look at what is happening here. This is because of the reflected, when you have the arcade, those blood vessels coming. So this is the shadowing because of the blood vessels, and this is a vertical scan. When you can identify the optic nerve, that becomes a horizontal scan. So just by looking at the scan, you can say whether it's a horizontal scan or a vertical scan. Having done that, then you can know whether it's a pseudocolors, it's a white on black or a black and white. These are the various options that can be discussed. And then whether it's a raster scan or a volume scan. So here you have a raster scan. This is one of the types of OCTs. Then you have different nomenclature. Basically, a raster scan is when you go from top here to bottom and you take multiple scans. Like in this machine, you take about 17 scans. And volume scan is, it records the volume in these zones which normally we have on the OCT. Now you also need to say that if you have the thickness pattern is machine dependent to an extent. The correlation of the actual thickness actually was shown that the retinal thickness is more correlated with the time domain OCT, which is about 180 to 190 microns. But when you look at the thickness pattern shown by RTV or other machines, it ranges anything from 220 to 290 microns. So you need to know which machine it is. And look at this picture. You have a patient with a macular hole, but the volume scan shows there's a macular edema. So that can't be correct. Obviously, because when the machine is plotting, it takes its marker here and thinks it as an edematous area when actually they should not have any thickness. So this is a fallacious, it's an OCT artifact. Then you have an artifact if the patient has blinked. So this is known as, the signal is lost, and this is because of blinking which occurs, and you have a false appearance of thinning of the retina. Then there have been reports of double fovea. There's nothing like double fovea. This is a movement artifact, and you can also have false vessels coming up on the imaging, which is actually not there. So you need to identify what are the artifacts. And then once you have got all that in place, you need to know what these layers are, because you need to know them clearly. These 6 layers on top and 6 behind, and you need to identify all of them together. Now, what is the role of vitreoretinal interface? If you see carefully, you can see here hard exudates, which you can correlate with your with the fundus picture. You can see the posterior hyaloid, you can see the vitreous, and you can see the highly reflective foci which are present within, and they all have an importance. We will not discuss what is the relevance, I'll just discuss the OCT findings. And then you have a vitreomacular traction, and you have an epiretinal membrane. You also have some cystic spaces, and you can identify different layers of the retina on this. Then we come to identifying what is the integrity. So now you look at the retina, the inner layers and the outer layers. And integrity of the inner layers is known as drill. So this was a beautiful paper which came up in 2014, where there was inability to identify the boundaries between the ganglion cell layer, inner plexiform layer, and inner nucleus. So you just see here that you can identify all the layers here, but in this particular picture, when you see, there is a defect present, and this is known as drill, where there is absence of the inner layers of the retina, while here you have an increased retinal thickness, but the layers are maintained. So a patient who has a maintenance of the inner layers is likely to have a better visual acuity, and a drill actually is a prognostic factor 8 months in advance. So when a drill is present, this paper had shown that 8 months in advance you can predict the loss of vision. Now you look at the outer retinal layers. So this is just a cartoon, a small little representation. You don't have so much of separation. But you can see here the external limiting membrane. You can see the inner segments, the ISOS junction or the ellipsoid zone, the outer segments, the RP and the Brooks membrane, which is normally seen as a complex, and then you have the choroid below. If you look at this picture a little more detail, you can see the external limiting membrane, the outer segments, then you see here the ISOS junction, then you have the Brooks membrane with the choriocapillaris complex and the RPE. Now, please look here, you will always have a little bit of protrusion here, and this is because of the increased length of photoreceptors with the longer outer segments of cones in the fovea. That is why you get this little protrusion, and this should not be considered as abnormal. This is all normal. Now how do we go about using this data in our treatment? When you're able to identify these zones when the patient is presenting, you can know that this patient is likely to do well. And this is the same patient which is 4 weeks post-Avastin. This is